Good afternoon, everyone. My name is Trần Thị Linh from Hanoi Medical University. I'd like to thank to the conference committee for giving me the opportunity to present our recent work. Today, I will present my study on evaluation of ultrasound-guided synovial biopsy result in the diagnosis of some hip arthropathy. My presentation will start with introduction, followed by material and methods, without discussion, and finally conclusion. As you know, the synovial membrane refers to a specialized type of connective tissue which line the inner surfaces of synovial joint capsule, tendon sheath, and bacille. Its primary role is to secrete the synovial fluid. Synovial pathology can occur in a wide spectrum of conditions, including septic arthritis, osteoarthritis, systematic inflammatory arthritis, crystal deposition diseases such as gout, CPPD, and neoplastic processes, both benign and malignant. Accurate identification of the underlying cause of synovial pathology is crucial for diagnosis and management. In case of inflammatory arthritis, differentiating between septic and non-septic etiology is very important for therapeutic decision making. Synovial fluid analysis is routinely used to confirm infection. However, in many cases, the etiology remains indeterminate when based solely on basic laboratory tests, imaging, or joint aspiration. Synovial biopsy is therefore essential, providing either a definitive diagnosis or exclusion of infection and malignant condition. Histopathology plays an increasingly important role in diagnosing joint diseases such as rheumatoid arthritis, tuberculous arthritis, pyogenic arthritis, and crystal-induced arthropathy. Synovial biopsy can be achieved in many ways. The context of surgery, fluoroscopy, or arthroscopy guided, or conducted at a plain needle or ultrasound-guided procedure. So there's a question, why should we choose ultrasound-guided biopsy on assess synovial pathology? Ultrasound-guided synovial biopsy, USDSB, clearly has the most well-balanced profile among synovial biopsy approaches. When cost, technical simplicity, patient acceptability, synovial sampling success rate, suitability for large and small joints, and suitability for serial biopsy are considered. Of interest, synovial tissue quality is maintained, and clinical and ultrasound evaluation do not change when repeat USDSB is necessary for the same joint. Plain needle and fluoroscopic guided biopsy are more difficult to conduct in small joints and joints without active synovitis, and have a lower success rate for obtaining synovial sample than other methods. Cost and technical simplicity favor plain needle biopsy, while suitability for serial biopsy and biopsy in small joint favor USDSB. Compared with arthroscopy biopsy, USDSB is less invasive and can be conducted in both large and small joints. Arthroscopy biopsy allows direct visualization of synovial membrane, but is more costly. Is performed in only a few specialized centers, require 2 operators and a dedicated environment, an operating theater or equivalent, and is not viable for small joints. There are no differences between arthroscopy biopsy, USDSB in terms of synovial sample quality, adverse event, or reported patient outcome. About the hip joint. The hip joint is one of the largest and most important joints of the body with deep location and complex anatomy. Ultrasound guidance facilitates accurate needle placement, reduce complication rate, and enhance diagnosis due in synovial biopsy of the hip. About the material and method, the inclusion criteria. Patients with abnormal hip synovium not otherwise defined by clinical examination, laboratory finding, US or MRI. Patient undergoing USGSB at the Radiology Center, Hanoi Medical University Hospital between July 2020 and February 2025. About the exclusion criteria, biopsy procedure not performed according to the protocol. Biopsy performed under US combined with another imaging modality. Incomplete medical record and coagulopathy, INR more than 1.5 and platelet count under 50. About the biopsy technique, all patients underwent clinical evaluation, ultrasound, and MRI prior to biopsy. Patients fasted for at least 6 hours. The procedure, risks, and benefits were explained, and informed consent was obtained. Samples were collected in 3 containers: histopatology, bacterial culture, and tuberculosis PCR. And we can see the position, patient supine, hip neutral or slight external rotation, knee extended, knee research from lateral to medial, just posterior to the sartorius muscle, directed toward the head-neck junction of the femur, and the equipment, sterile environment, the convex and linear probe. Biopsy were performed by radiologists with 7 to 10 years of ultrasound-guided interventional experience. The procedure was conducted step by step. The first, prepare patient and instrument, sterilize skin, wrap with sterile cover, apply sterile sheet to probe, identify synovial target, avoiding vessel, local anesthesia, 2 to 5 ml of lidocaine 1%, non-intra-articular. Aspirate joint fluid if abundant. Introduce 18-gauge coaxial choker into joint space, adjusting trajectory along synovium. Often 3 to 4 tissue core for histopatology, 1 or 2 for PCR, 1 or 2 for microbiology. If we are suspected, additional slide prepare for crystal examination. Procedure, ultrasound to detect complication, and finally abdominal compression and advise 48-hour rest. This is the instrument and the ultrasound imaging of the biopsy. During and after the biopsy, the patient will assess the pain level by a visual analog scale, mild, moderate, and severe. Some complication can be seen.
Yeah, we are so sorry, Dr. Linh, because your time is over,
sorry.
and we are discussing, and we will stop here. We stop here.